Good evening, everyone. We will just wait a few minutes to get everyone logged in. Good evening, and welcome to tonight's presentation on women and heart disease. Thank you for making your health a priority by spending this time with us. I'm your host, Stephanie Nichols, Heart and Vascular Services Marketing Director for Franciscan Health. Our cardiologist has some great information to share with you this evening. By the end of our time together, you will know more about women's risk factors for heart disease, situations unique to women in deciding to get care, why a delay in getting care or taking steps to prevent heart disease can mean to your recovery from treatment, what you can do today and tomorrow to lower your risk of heart disease and to contribute to a better outcomes should you need care or surgery. Before we get started, I'd like to share a few housekeeping items. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. If you have questions to ask our presenter, please type them in the chat window. We'll be answering your questions at the end of the webinar during our Q&A time. Our administrator, Kirsten, is taking care of everything on the back end this evening. If you experience any technical issues, just type them into the chat window and we'll work to resolve them as quickly as possible. If you miss anything, no need to worry. We'll send the recording of tonight's presentation to you in a follow-up email. So let's get started. First, we would like to know a little bit about our participants. Right now, we have about 54 people listening tonight and expecting a lot more. So our first poll question, please choose the answer that best describes why you're interested in this topic. And you should see the poll question pop up in a white box. All right. Let's see what everyone's interest in this topic is. Okay, so we can see that about over half of the team here has some risk for heart disease, including high blood pressure, and wants to know more. There are several of you who want to learn how to reduce your risk of heart disease. And also those who have heart murmurs and atrial fibrillation want to learn a little bit more about that, or those who have had a close female relative with heart disease. So we will discuss all of that in tonight's webinar. Our presenter tonight is a cardiologist on our Franciscan Health medical staff. Dr. Kendra Marsh Cates is a graduate of Meharry Medical College in Nashville, Tennessee, and she completed her residency at the Yale School of Internal Medicine and a fellowship at the University of Illinois. She specializes in cardiac imaging, cardiovascular disease prevention, heart failure, and women's health. Welcome, Dr. Marsh Cates. Kirsten and I will turn the program over to you now.
All right. Well, thank you. And good evening, everyone. I really appreciate you all being here. And on a personal note, the reason why I'm interested in this topic is because I am a woman. And so therefore I have risk for cardiovascular disease. And so the goal of this talk is to hopefully gain a better understanding of the seriousness of heart disease, the prevalence of heart disease amongst women, and also how we can empower ourselves to prevent it, and also to help give ourselves the best shots of survival if we've been diagnosed with it. So I'd like to make this talk a little bit more engaging, and I'm going to treat it somewhat like a quiz. And I promise that the questions aren't going to be super difficult. They're just simple true and false questions just to gain a better understanding. And just as a side note, I read about a survey that was conducted. I think it was actually just before the pandemic, around 2019. It was a survey of adult women in the US, and the simple question was, what is the number one cause of death amongst women in the United States? What's the number one cause of mortality? And a majority of women actually got it wrong. Only about 40 to 45% of women knew what their number one risk of dying was, what the number one disease condition was. So hopefully at the end of this talk, we can clarify some things and get a better knowledge of what our risk is and how to combat it. So first question, true or false? Women do not get heart disease. Next slide. Next slide. So the answer is, of course, false. Heart disease is the number one killer of women. Next slide, please. So when we look at all the possible causes of disease and death amongst women as of 2021, of course, the top three are heart disease, cancer, and COVID-19. And of those three conditions, heart disease still remains the number one cause of death, above and beyond any cancers or any COVID infections, if you can believe that. Next one. True or false? Young women are not at risk for heart disease until after menopause. That's an older woman's disease. Next slide. And that's false. Among females 20 years and older, nearly 45% are living with some form of cardiovascular disease. And less than 50% of women entering in pregnancy in the United States have good heart health. The reason why I included that second part is we think about younger women, childbearing age, as being at the peak of our health, but we're finding that alarming numbers of women are actually not as healthy as they think, and cardiovascular disease is starting earlier and earlier. And when I mentioned that survey that was conducted to assess our knowledge of how prevalent heart disease is amongst women, it was discovered that older women in their 40s and older, had a better understanding of cardiovascular disease risk as the number one cause of death of women. But women under 35 actually were unaware that it was a danger to their health. So it's a growing number of younger women are not realizing or recognizing their risk of cardiovascular disease. Next slide. And then amongst younger women, what we think of often is motherhood, and cardiovascular disease is actually a major complication amongst new moms. Cardiovascular disease is the number one killer of new mothers. It accounts for 1 out of 3 maternal deaths, and Black women have the highest maternal mortality rates. Next slide. So just to think about the risk of cardiovascular disease in these young expectant mothers, we have to first think about what the normal changes that we expect in our bodies during pregnancy that occur. And we're expected to have an increase in our blood volume, an increase in the work effort of our heart to circulate blood to help maintain the health of not only our own bodies, but of our babies. But there's also increased demand on other organs like the kidney, the liver, the lungs, the stomach, and the intestines. And so those are expected changes. But in someone who is coming in with compromised health, they may be at risk for things like edema, which is swelling in the legs and in the arms, forming blood clots, high blood pressure, heart failure, and even heart attack. Next slide, please. So pregnancy is a stress test. And about 10 to 20% of women will have some sort of issue during their pregnancy that may not directly be considered heart disease, but actually it increases our risk of having heart disease in the future. And these conditions are high blood pressure, preeclampsia, gestational diabetes. So women who have these conditions in the younger years, especially during pregnancy, have up to a fourfold risk, lifetime risk of having heart problems like heart attack and death from heart disease. So it's not just a disease of older women. Next slide. And just to reiterate, the risk of heart disease and preeclampsia. So amongst patients who have preeclampsia versus patients that do not, they have a significantly higher risk of developing things like hardening of the arteries, or what we call coronary atherosclerosis. And that's represented by the red bar on the bottom graph. Next slide. Gestational diabetes, just another quick reminder. So women who do suffer from gestational diabetes with a history of this condition have nearly a 50% increased risk of overall cardiovascular disease. So even when you're going to see your cardiologist and you're talking about your risk and your heart health, and maybe you're in your 50s or 60s or older, if you remember those times, even during your childbearing years that you've had these conditions, they're important to talk about, because they're just as important risk factors as actually having a smoking history or high blood pressure or being overweight or high cholesterol. These are things that we need to know about so that we can help reduce your risk of developing heart problems. Next slide. So another question, pardon the typo, true or false? Menopause causes heart disease in women. So women who are going through the change of life or menopause, it's a direct cause of heart disease. Next slide. That's actually false. So going through menopause in itself does not necessarily cause heart disease, but menopause actually marks an important milestone in life. It's a point where women's cardiovascular risk can accelerate. So these are times when we're, in our 50s or older, maybe a little bit younger, and we're developing things like higher blood pressure and difficulty controlling our blood sugars. It's not as easy to lose that weight as it was when we were younger to get to a healthy body weight. Or maybe just the demands of our lives have tended to make us more sedentary and not as physically active. So there is this point in our life where we're realizing that there are things that can go wrong, and we're more focused on our health, and we realize just how critical it is. So it's kind of a pivot point in our life to recognize those risks or dangers. Next slide. True or false? Current cardiovascular disease or heart disease research applies to both men and women. So the studies that were conducted equally applied to both genders. Next slide. So that's false. So less than half, actually 38% of participants in clinical trials are actually women. Next slide. And so women tend to be underrepresented along with ethnic and racial minorities in positions where they design and create some of these trials and actually conduct these trials. And so they're tend to be underrepresented in leadership, maybe under-enrolled in cardiovascular disease trials because of this. Other points of exclusion from research, especially in cardiovascular disease, might be because of age or different ways of administering or receiving care, maybe some logistical barriers as to getting to these clinical visits or even getting to these trial visits, because some of these trials can be labor intensive. They might require frequent follow-ups, either by phone call or office visits, that may not be conducive to taking care of family or making it to your job on time or all the other responsibilities that you might have that might make it hard to break away. Limited diversity in leadership, and then also some social factors that might contribute to underrepresentation of women in trials. Next slide, please. So the thought is, if we improve the inclusion of women in medical research, we might have a better opportunity to help reduce some of the risks associated with heart disease by improving treatment and preventative care targeted towards women. And so simply by increasing gender and racial diversity among trial leadership to have more of a vested interest, and including a wider variety of people in these trials would be very helpful. Innovative approaches to increasing recruitment of participants, maybe a broader distribution of sites or access to these trials, and also opportunities for remote monitoring so that you don't necessarily have to be physically present for some of the follow-ups, and other measures that could narrow the gap between genders and involvement in these cardiovascular trials. Next slide. So, true or false? Men and women receive the same treatment for heart disease. Next slide. That's false. So women are less likely to receive evidence-based therapy for cardiovascular disease. Next slide. And there is actually some data to support some of the treatments that we actually consider crucial to prevention of heart disease and heart events may not be, women may not be getting the same amount of treatment. So one example is statins, and statins tend to be controversial. I know in clinic, I'm always a little bit weary when I have to mention to a patient that, yeah, we should consider statin therapy, but I try to be a little bit brave because you never know what the response is going to be. There's been a lot of controversy as to, is this going to hurt me or is this going to be helpful for me? And so those are some things that might maybe reduce the likelihood that a person might be willing to try a certain drug. It's just certain feelings or beliefs toward them. But for whatever reason, one example being statins, women tend to be less likely to be treated with them, even though we know that statins reduce the risk of dying from heart disease and greatly reduce the risk of heart attacks and strokes. Most women are not offered statins, or perhaps they've declined statins, or they're more likely to discontinue. And so that's kind of a big deal because the slide doesn't really give a good reason as to why this is happening, but I think the important question is, or to know, is that it is happening. And for some reason, women aren't getting access to this very crucial drug in prevention of heart disease. Next slide. The other big risk factor is high blood pressure. High blood pressure, also known as the silent killer, because a lot of people don't have major symptoms. Sometimes the first time they find that they have very poorly controlled blood pressure is when they go for a health screening and get their blood pressure checked. And high blood pressure women account for almost 52% of high blood pressure deaths. So half the population, but more than half the number of deaths from a very treatable condition, high blood pressure. And just as a review, normal blood pressure is 120/80 or less. So I'd have quite a few patients that would argue with me and say, well, that's too low. I might pass out with that, but that's a perfectly normal and very good blood pressure. We're actually considered pre-hypertensive or elevated blood pressure between 120 and 129/80. We start classifying patients as hypertension, 130/80 or greater, and very high blood pressure, 140/90 or greater. And crisis or critical, the red zone is 180/120. But once you start to get to the pink zone, that's when you start to notice over the long term increased risk of stroke and kidney problems, and even heart failure if we don't get under control. So it's not a benign thing. But we're finding that women are disproportionately affected or more likely to die from this condition. Next slide. So, and if we do get diagnosed with hypertension, the interesting paradox is that we're more likely to be treated than men. So we're on some drugs, but we're less likely to achieve that goal of a healthy blood pressure, that 120/80 or less than 130/80. And that's critical for prevention of those long-term problems. And then if we combine the two treatments, statin therapy to lower cholesterol and also to help prevent heart problems, along with blood pressure control, the two together are the double attack on heart disease and cardiovascular disease risk. They work well together. So alone, controlling blood pressure and adding a statin work wonders for reducing risk. Together, it's even more phenomenal. And then when we do nothing, we put people at serious crisis. So it's so important to be on those drugs and hit those targets for management. Next slide. And then most heart and stroke events, as we talked about, are preventable. So that's the tragedy of it all, is that a lot of these things we don't necessarily have to go through if one, we're proactive about our health, but that we also, as healthcare providers, make sure that we're diligent on hitting those milestones for everyone, both male and female. And so things like cholesterol management and our targets, definitely we want to reduce our bad cholesterol very aggressively for people with high risk factors for heart disease. But even without having high cholesterol, we know that statins and cholesterol medications can be healing and even protective of the heart arteries and of the blood vessels without having super high cholesterol numbers. Managing diabetes. So those of you that know, if you know, hemoglobin A1C, which is the number that tells us the average blood sugar over the course of 3 to 4 months, that percentage should be less than 7 for optimal prevention or heart health. But even the lower, the better. So even, less than 6.5 also helps prevent things like kidney troubles and kidney disease and those sorts of things. And of course, if you don't have diabetes, it's better not to have a high number at all, but maintaining healthy blood sugars, avoiding those processed foods and refined sugars and carbs. There's no such thing as a good cigarette. So smoking cessation. So even one is bad. And then, of course, our younger generation of folks, our millennials and our Gen Zers, and maybe some of our young Gen Xers are vaping too. And all that's bad for the heart. The poisons or toxins in cigarettes not only increase risk of heart disease, but cancers. And then we know that the high concentrations of nicotine in things like e-cigarettes or exposures from vaping can accelerate the heart rate, can overtax the heart, causing things like heart failure, high blood pressure, arrhythmias, which are irregular heart rhythms, and stroke. And then we talked about keeping a healthy blood pressure, but exercise. My partner, Dr. Hamoudi's one of the observers today, and he's a big proponent of physical activity and exercise. He practices what he preaches, but at least 5 days a week, 30 minutes a day, or what averages out to 150 minutes a week of at least moderate exercise, but even something's better than nothing. So I tell my patients, if you're just starting out, maybe even stand for a couple minutes while, in between, your work breaks or watching your favorite television show. Our healthy diet, some examples are Mediterranean diet, DASH diet, but again, it's really staying away from highly processed, highly refined foods, heavily plant-based diet, at least 5 to 8 servings of fruits and vegetables. And then if appropriate, blood thinners like aspirin or Plavix for those patients that need it. And that's a decision that should be had with you and your doctor if that's necessary. Next slide, please. So also on the kind of more extreme end of things, the ultimate consequence of heart disease is what we call sudden cardiac death or cardiovascular death. And there's people that have these sudden events. They stop breathing, their heart stops working. And if it happens outside of the hospital, it's kind of a dreaded moment because you're more likely not to survive if that happens. And we found that women actually, a smaller number of people that, less people than should actually get what we call bystander CPR when a rescue worker, EMS worker, medical worker outside of a facility outside of a facility administers CPR, life-saving techniques to help revive a person. Women are actually less likely to receive those actions. And CPR, which is cardiopulmonary resuscitation, is definitely a survival benefit the earlier it started and the higher quality of administration of those important chest compressions that we get. It's important to survival. But there's some fears of those bystanders of inappropriate touching, perhaps having misconstrued as sexual assault or injured a victim. But when someone's life's in crisis, those things are not the priority. The biggest priority is getting that person revived again. And women, only 39% receive bystander CPR in those situations. So learning hands-on only CPR and being ready to administer to everyone should be the goal. Next slide. And just to show how simple it is, get your smartphone out, call 911, and begin to push on the chest. And that's a whole separate discussion. And the American Heart Association, as well as various organizations, American Red Cross, have wonderful community classes on this. But just simply doing that can save a life. And so without hesitation, if there's a suspicion, just go ahead and do it. Next slide. And then this slide just illustrates when the survivor gets involved, more than a third of patients actually do survive when they get bystander CPR. And when survivors, when there is limited bystander CPR, 11%, roughly about 11% survive. So very important, without hesitation, without reservation, for all people to consider that if you see someone in distress. Next slide. So the other thing that you hear a lot about is, maybe women tend to not have their symptoms recognized when they are having heart problems. And the classic situation is having a heart attack. We all expect a Hollywood heart attack to be our big red flag that something's wrong. The crushing chest pain, the profuse sweating, and the immediate distress that you just know it's happening and you're ready to go to the hospital and get some life-saving treatment. But what does a heart attack actually look and feel like for women? So first we have to understand what a heart attack is. So it starts with, and this might be years or decades earlier, the formation of fatty streaks in our arteries, the arteries that supply blood to our heart muscle. And those fatty deposits can become thicker and form little plaques and clots inside that narrow the artery and limit blood flow. Next one. That causes the heart muscle to actually become starved for blood. It strangles the heart muscle, and so that leads to development of pain because that blood eventually gets blocked off if that plaque or blockage isn't treated. Earlier on, those things that we talked about, controlling blood pressure, controlling blood sugars, controlling cholesterol, exercise and diet, helps to reduce or prevent buildup of those early plaques. But if we don't get a chance to do those things, it may lead ultimately to complete blockage or a clot plugging up that artery and then leading to the heart muscle becoming very bruised or sick or even dying. And that's what causes the pain of or discomfort or the symptoms of a heart attack. Next slide. So signs of heart attack for women aren't necessarily, and I use this term because I got it from participating in many Go Red for Women American Heart Association events, but the Hollywood heart attack, it sometimes can be subtle. It can present like a stomach bug, nausea and vomiting, or maybe that I'm getting a little out of shape, so shortness of breath without any chest discomfort. Or maybe I feel like maybe I'm just carrying a lot of tension because I've had some stress in the family, so I got some pain in my upper back and shoulders or my neck and jaw. Or fainting spells, cold sweats that could be mistaken as hot flashes, dizziness and lightheadedness, of course, chest discomfort. Many people still, both male and female, present with it. Paleness, being cold and clammy, restless sleep, and being unusually tired. Next slide. But this slide really hits home because it's one of a few examples that I have of the non-typical signs of heart attack. And I had a woman present to my clinic, and she had suffered the loss of her mother. She was best friends with her mom, and her mom died about a year prior. And actually, immediately after her mom passed, she had major hospitalization for heart failure. And it turns out that she had what we call broken heart syndrome, where her heart temporarily became weak because of extreme loss and emotional distress. And she was treated, and eventually her heart function recovered, and she did well, and she thought, well, I'm fine. So about 11 months later, she comes to the office saying, well, I have a positive outlook on things. I've gotten therapy. I feel good, but I'm just really tired. I'm really tired, and I'm not sure if it's my heart or not. And to top it all off, I don't know what's going on with my cheeks. They're rosy. I must have rosacea or something. They're just very red, almost like I'm blushing. I don't think it's menopause, she said, because I finished that 12 years ago. So we started off with doing a scan of her heart, a cardiac CT scan, which showed a lot of blockages in her heart arteries. So I sent her to my partner, Dr. Hamui, for a heart catheterization. And in the upper left-hand, in the upper right-hand corner are a depiction of what was seen during the heart cath. So it's not our actual images. These are just stock images, but it's representation. And like those arteries you saw in the early pictures of what a heart attack is, these are her right and left heart arteries, and many of her main branches were blocked. So it turns out the flushing of her face wasn't recurrence of menopause. It wasn't stress or anxiety. And the fatigue wasn't just her not exercising enough. She really and truly was on the verge of a major heart attack. So she ended up getting bypass surgery, and her symptoms improved. So it's an example of how you have to be aware at all times that your symptoms may not be what you expect in the textbook. Doctors, we have to do this all the time. You always have to ask, even if it does sound like a wild situation, you have to think of all possibilities. But even when we're observing our own symptoms and listening to our own bodies and symptoms, if something's not right, don't write it off. Get it checked out. We're going to skip this slide because I don't think that it's giving any new information. So that's great news, Dr. Marsh. Thank you for all that information. But I was asked, when you present the problem, so what are we going to do about it? What do we do now? So what is the what now? How do we fix or remedy the situation of one, getting the word out there that heart disease amongst women is actually a major problem, the most likely cause of death among adult women? And then what do we do to increase our chances of survival and to live a long, good, healthy life in spite of that fact? Next slide. So the first call to action is take care of yourself. And I can't reiterate enough, prevention at any level. We have different degrees of prevention, primary and secondary. Secondary, the cat's out of the bag. You've had an event, a heart attack, a stroke, or some kind of blockage that needed some fixing. But it's not, so we want to prevent the next event. But we also, for those of us who haven't had those events, we want to make sure we don't have the first one. So it's always prevention at every step of the way. And again, I can't say it enough. The most important things are blood pressure control, hitting that less than 130/80 mark, or as low as we can tolerate. Cholesterol management, and if indicated for whatever other reason, statin therapy is high on the list as one of our prevention tools. There's no such thing as good cigarettes. All of them are bad. So if you're a smoker, stay away from secondhand smoke. Just stay away. A heart healthy diet, rich in plants, fruits, and vegetables, and legumes if we can. avoid all processed foods when possible. Really good diabetes control, but if we know that we're someone who's at risk, and then do those good things like physical activity, heart healthy diet, just to help make sure that we don't develop diabetes. And then there are certain diabetes medications that can benefit folks in prevention of heart disease too. And so those will probably be discussed in future talks. But these are all very important things to prevent our risk of heart disease, heart attack, and stroke. And then aspirin when necessary. And of course, physical activity. Anything's better than nothing, but if we can get at least 150 minutes of cardiovascular activity, whatever your choice is, and if it's high impact, so if you're a CrossFit or boot camp or extreme marathon runner, so 75 minutes of high intensity workout for those of you who are real donors. Next slide. And of course, get involved. I mean, there's nothing more empowering than increasing your own knowledge, increasing your own skills, knowing that you can, not only protect and help yourself, but you can help your family, your loved ones, your neighbor, your community. I'm a big proponent of as many people as possible learning CPR, especially women, knowing that we're less likely to get it if we're having issues. But the other thing is, we're even having kids that are trained in CPR. When I was in Wisconsin, I think it's actually a national effort, they were teaching kids as young as 3rd grade CPR. And many kids have actually had the opportunity to help their classmates and loved ones by learning those skills. And then go and visit, if you have a chance, the Go Red campaign, the American Heart Association website under the Go Red campaign, which was specifically created in 2004 to help raise awareness of heart disease in women and to help tell us how to get empowered and how to prevent this illness amongst ourselves and in our community. There are tons of community education programs. So if you like programs like this one, there's plenty of programs, especially between your medical care providers who like to get involved with the American Heart Association and Go Red campaign. And then when in doubt, ask a cardiologist. I always say there's never a bad reason for you to come and see a cardiologist. There's a question about your risk in relation to a family history or other conditions, or if you just don't feel right, there's never a bad reason to come see one of us. And then also, please do not ever ignore your symptoms. There's nothing too small or trivial. Everything is important. Next slide. I'd like to thank you all for your time. That's all I have.
Thank you so much, Dr. Marsh-Cates, for sharing some of this great information with us tonight. We will finish the webinar with a Q&A with our panel of cardiology experts, Dr. Marsh-Cates, and her colleague, Dr. Omar Hammoui, cardiologist and medical director at Franciscan Health Heart and Vascular Institute in Olympia Fields. So here's some questions we've received during the presentation. Please, if you have questions, put them in the Q&A box at the bottom. You can click on it and ask your question anonymously or with your name, and I will read them aloud and our panelists will answer them. So the first question we have is, it sounds like our symptoms for a heart attack align with menopause or aging. How do we really know?
Well, that's a very good question. So when you say, how do we know, usually as patients, it's hard for us to be objective. And so I think if you have a symptom or a concern, you should really go see your doctor. And normally we start with our primary doctor or maybe our OB/GYN if we're still seeing them. So I guess what we're getting at is things like feeling sweaty or the hot flashes, the fatigue that can sometimes happen, all those changes that can occur through menopause. And yeah, that is tough to tease out. But if you have other risk factors, or there's a family history, or maybe there's something in your own clinical history, some data point that's interesting, or something on your exam, you really do need to see a specialist. And that's what we're trained to do. We're detectives in heart health. So we can help you really tease out effectively, what's what. Is it heart or is it not? Cardiologists, we're really, really good at that. because what we do is think about the heart 24/7. So when in doubt, come on in, come see a cardiologist.
Thank you. Another question, how much does genetic factor into heart disease?
Well, Dr. Habui, do you want to take that one?
Sure, I'll be happy to. So there are set criteria where we utilize genetics as a risk factor. For example, a man with a family history of premature heart disease before the age of 55, a woman before the age of 65. That should make all the first-degree relatives high-risk people. And if we have that, automatically we should try to prevent heart disease, not at that age, maybe 20 years earlier. As Dr. Marsh said, these fatty streaks and plaques, they start 10, 20, 30 years before they manifest. And genetics, everyone in our families have some sort of heart disease. At some point, 70, 80% of all people will have heart disease. But if we have people manifesting heart disease at a younger age, there are certain syndromes called familial hypercholesterolemia, people with cholesterol that is particularly harmful. Those people get heart disease in their 30s and 40s and early 50s. So if we have any of those family members, that should prompt prevention way before symptoms. And again, Dr. Marsh mentioned symptoms and particular symptoms to women and unusual symptoms. Those are extremely important. However, if we are waiting for symptoms in heart disease, many times we have lost the game. And there's a slight difference between men and women here, and men have the worst of it. 70% of first symptoms in heart disease in men is a heart attack, and 50% of first symptoms in women is a heart attack. So we don't want to wait for symptoms. If we have symptoms, we should take care of them very quickly. However, we should prevent the disease way before we get to the symptoms.
Thank you. Now, a couple of questions are starting to come in now. So another one is 81 milligram aspirin recommended for 50 plus years old with no individual risk, but a family history of heart failure on both mother and father's side?
No.
I guess, is it recommended?
No. So aspirin, which we used to love, and maybe 20 years ago, every man over the age of 40, every woman over the age of 50 were probably on aspirin, and probably many people are still taking aspirin because someone recommended them, usually not an up-to-date doctor. But I would say aspirin right now is only positioned for people with heart disease. So when we have heart disease like a heart attack or a stroke or blockages in the peripheral arteries, absolutely, by all means, these people should take a blood thinner, usually a baby aspirin. However, in prevention, in people without problems, we do not prescribe aspirin overall anymore. We do not. We only prescribe it to very high risk people. But people without heart disease in general need to take care of their cholesterol, more importantly than taking an aspirin. They need to take care of their blood pressure, more importantly than aspirin, and their diabetes, more importantly than aspirin.
Thank you. Does high cholesterol that's treated with statins still cause risk for a heart attack? Mom and dad both have high cholesterol and take statins.
So we actually know, oh.
Go ahead, Dr. Marsh.
Yep. So if the high cholesterol is treated, the first goal is we want to try and at least get about a 40% reduction from the highest amount. We used to have a set number that we treat, but we know that there are some people with very high cholesterol numbers. And so we want just a relative reduction. And then once we kind of get to that point, then there are other things that we may consider adding to further reduce the cholesterol numbers, especially in folks who already have proven heart artery or vascular problems, like Dr. Hamui mentioned, so blocked arteries in the legs or maybe previous stroke or heart attack, we might add other medications that are not statins like Zetia to help boost the potential. And then also we have these injectable agents now, they're called PCSK9 inhibitors that are usually a couple times a month. And they can, in addition to statins or in lieu of, if someone has an intolerance to statins, really drive those numbers down. But really that when we get to that point, we're talking about secondary prevention. So people that are at risk for their next event or their next problem or have severe blockages, and we really need to get those numbers down aggressively.
Thank you. Would symptoms of a heart attack come on suddenly or last for days?
Actually, oh, go ahead. Dr. Hamui actually is an interventional cardiologist, so he sees a lot of this.
Yeah, last night I saw a heart attack as well of a woman who never had any problems. So this is quite common and suddenly. And if people have symptoms for 2-3 days, continuous symptoms, that almost tells us it's not a heart attack. You cannot have continuous symptoms for a whole day, for 24 hours or longer, having a heart attack. Once you have a heart attack, if you survive it, your symptoms will go away. They will not last a long time. Now, you can have stuttering symptoms or symptoms that come and go, and you should respect those symptoms and address them very quickly. But usually, heart attack symptoms happen 50% of the times without any preceding warnings in women, and 70% of the times without any preceding warning in men.
Okay, thank you. Does having high blood pressure but taking beta blockers mean you could be at risk for heart disease?
Well, having high blood pressure alone is a risk for heart disease. Beta blockers in themselves is just a type of blood pressure or type of heart medication. There are many reasons why we might select it. And that kind of goes along with how we treat blood pressure anyway. So our guidelines recommend a certain target, but there's a little bit of variety depending on what medications we select. So a beta blocker tends to slow the heart down a little bit, and it helps to soften our heart's response to adrenaline. So adrenaline is what makes us revved up for fight or flight. But in normal circumstances, it just makes our heart beat harder and faster and tighten up those blood vessels. And so these medications we kind of use in folks who might have irregular rhythms or fast heart rates that would benefit from it. But a lot of people end up over time needing more than one class of medications. We might add something different, like a water pill or a medication like a lisinopril, which is an ACE inhibitor. So just different classes of medications that work at different target sites to help lower blood pressure from various angles. But it's the blood pressure really that's the main risk for having the heart disease.
Thank you. I don't feel good on statins. What else can I do?
A lot. So in the past, we did not have many options, but like Dr. Marsh Cates said, now we have, I believe, 7 or 8 effective FDA-approved medications that lower lipids. So we have lots of options now. I would say, though, most of the time when people say, oh, I had a side effect on a statin, they really did not have a side effect on a statin. If people come in to a treatment, whether it's a statin or something else, you know, hating medicines, having heard negative things about them that they believed, they probably will have a side effect, and it's not a true side effect. This is what we call nocebo. You know, you take a pill, and an hour later, it takes weeks for the side effects to develop. An hour later, you start having side effects. So I think, and I saw one of the questions in the chat box, people should have discussions about these topics with their physicians. Most of these medications are very safe, and they have very little side effects, something in the order of 1 to 4%. So, and side effects usually are very well recognized and very effectively managed. So I would say, why do we take medicines? for their effects, for their benefits. And we know if we are on good, effective statins or similar medications for a long time, we can reduce heart disease sometimes to the order of 80%. So they are some of the best things we have. And I urge people to be very patient with medications that are for prevention. And it's hard because, you know, you're preventing a silent condition, and you take a medicine that sometimes can be costly, and you may have a minor side effect here or there. However, we should not lose focus of what we're trying to prevent. And that is the number one killer, as Dr. Marsh said, showed us.
Thank you. Is the Lifeline screening good for testing for heart blood flow?
Say that again.
So like the Lifeline, so the carotid ultrasound, the calcium score, aortic, abdominal aortic ultrasound, you know, the screening test. It depends. So definitely great for, remember how we talked about primary and secondary prevention. So definitely great if you've never had a diagnosis of heart problems or heart disease. So someone who's had bypass surgery or stents, probably not a great test to do. But if you're someone who's really trying to get on top of your risk factors and prevent that first event, it actually can be quite cost effective and useful, especially, and Dr. Ramoui and I both agree on this, the calcium score portion, because that scan for now almost 2 decades is a very useful tool in predicting up to 5 years your risk of having heart attack, death from heart disease, heart problems, just by calculating the amount of calcium buildup in the heart arteries. Just a score, not even telling you how narrow things are. And then we can also measure the thickness of the walls of the neck arteries, the carotid arteries, and the size of the aorta. And those are all what we call surrogates or markers for risk of vascular disease. So getting that scan and then bringing it into a preventative cardiologist or a physician that specializes in cardiovascular disease prevention can be an invaluable tool to writing your prescription overall for wellness and prevention of heart disease.
And when in doubt, you know, just discussing it with your physician. There are so many screening tools nowadays, and they're all very easy and quick and affordable. So which screening tool to use on which patient, I think it's become a subject of discussion, and it would be very valuable to discuss it with your primary physician or with a cardiologist.
Okay, thank you. We have a couple more questions and just a few more minutes left. So this person said, thoughts on heart and lung scan, which I know you just brought up, Dr. Ramoui, that Franciscan has. If so, how often? I've had one 5 years ago. High family history of heart disease. Mother died at 69 or at 60. Her parents 67 and 68. All of heart siblings. Siblings both have high blood pressure. I do not exercise and watch what I eat on moderation, and I'm not overweight. What recommendations would you have for her?
Dr. Marsh?
I'm chuckling. So you said you do or you do not do all those things, exercising, moderation?
It said, yep, it says does not exercise, but does eat in moderation and is not overweight, but has a strong family history of heart disease. Her mother died at age 60 and she's 62.
Yeah, so the heart scan, the calcium score in particular, its biggest benefit is kind of a yay or nay that, you know, you have the beginnings of heart artery disease, of hardening of the arteries or not. So if you already have a calcium score of like 100 or 200 or 300 or 1,000, it doesn't make sense to repeat it because it's answered our question. Yeah, you have coronary artery disease. And so we need to start treating you as if you've had a stent or a heart attack and hit those risk factors. There are some studies that support, and these are mostly kind of like little, small little local center studies that show that maybe if you have a calcium score of that is totally zero, which is considered low risk, that repeating it again in 5 years may be helpful to see if there's progression or development of disease. But once you get your answer the first time, it's kind of, you know, we've already answered that question. Like Dr. Ramoui said, there are so many other tools that we can have to help continue along to see how effective our interventions are as far as screening after that.
Okay, thank you. Let's see. Any healthy blood pressure tips?
Well, the number one, actually the most, besides diet, which is still very important, there's controversy with people saying, salt and this and that, but eating a healthy diet, maintaining a healthy body weight, or at least weight loss, irrespective of goals, can be helpful, but also cardiovascular exercise. So heart healthy diet plus cardiovascular exercise on a regular basis, you can get a pretty significant lowering of your top and bottom number as far as blood pressure goes. But you also want to avoid those high salty foods. And so I tell my patients, anything that has a long shelf life, that's canned or preserved or salted, so hams, anything pickled, sauerkrauts and things like that, stay away from in favor of fresh meats and fresh vegetables and fresh fruits. Highly plant-based as well, are very helpful. I know a lot of people are getting into like various supplements. You still want to be careful with things. I know people are looking into things like garlic and beetroot and I forgot the other, hawthorn root. There's not been any supplements that have been proven to be helpful or effective in lowering heart disease risk, even if they do have some anecdotal evidence of lowering blood pressure and things like that. So I would definitely avoid if possible. And if there's a strong desire to want to start these things, to have a strong, have a serious discussion with your healthcare provider.
Okay, just two more.
Yeah,
Are you
just
more
one
at risk? Oh, sorry, go ahead, Dr. Hammoui.
before we leave the topic, because
Yes.
it's very important of blood pressure. Few more tips that I want to add. Good sleep. Good sleep. People ignore or neglect sleep. Good quality sleep, 7.5 hours of good quality sleep. Avoiding stimulants. That's caffeine and nicotine. Avoiding stimulants certainly will help. And recently, we saw some nice, very encouraging data on salt substitutes that have some potassium. So if you're not on a medicine that can potentially raise potassium, then a diet rich in potassium and potentially some salt substitutes that have potassium in them, they've been shown to reduce blood pressure as well. So these are all helpful in addition to medications or before you get to medications if you want. Thank you.
Okay, great. Are you more at risk for a heart attack if your mom had a heart attack or if your dad had a heart attack, or is it equal?
I think that's equal opportunity.
How long should a female patient be on a blood thinner after surviving a heart attack and having a stent placed?
Probably for life. Probably for life. Female or male, they should be. But we have moved lately into less and less. So whereas we used to put people on 2 blood thinners for a year or sometimes 3 or longer years, now we have moved down to 1 blood thinner many times. So this is a discussion to have with your cardiologist, whether we can de-escalate, but certainly 1 blood thinner is necessary for the rest of your life.
Okay, last question here. It's a long one here. So I have heart disease from both my parents, but have been rather healthy myself at age 57. My youngest daughter, who's 23 years old, is a former college athlete and continues to exercise 90 minutes a day, lifting and cardio, and she eats very healthy. She is on levothyroxine for the past 2 years and is now having cholesterol numbers close to 300. Suggestions for a sports cardiologist, or what would you suggest?
Yeah, I would say not related to sports. This is probably related to genetics. And, if you get cholesterols up in those numbers, assuming that her thyroid condition is now controlled, then this is genetic and she needs to be on cholesterol lowering medicine. If she's exercising 90 minutes a day and her cholesterol is 300, that's just, pure genetics. She needs to be on cholesterol lowering medicines, even sometimes at her age, though this is a childbearing age, and we may need to have discussions on, to hold the medicine at the time of, pregnancy and delivery. But certainly this number up to 300 requires intervention even at a younger age.
And actually, the interesting thing is the cholesterol therapies that were initially developed were looking at folks just like this who had genetic elevations in their cholesterol. So people that were otherwise surprisingly healthy for the time, who developed major heart events because they had very high cholesterol from genetic inheritance. So that's an important independent risk factor. So just to co-sign what Dr. Emily said, very important to treat.
Thank you. Thank you both, Dr. Marsh-Cates and Dr. Hamoui, for this great program and for all this wonderful information on women and heart disease. And thank you to our participants for attending. You've all taken an important step towards improving your heart health. We'll send you an email with a link to this session. We encourage you to share it with the women in your life. We will also have you fill out a brief survey about the program, which will be in your email. Your input is going to be valuable for future webinars. And if we didn't get to your question tonight, we'll do our best to contact you by phone number or email address you provided at registration. On behalf of everyone at Franciscan Health, thank you for being with us tonight and have a blessed evening.
Thank you.